Welcome back for Learning Plan 3, Antimicrobials, Anti-Infectives. Some things to remember. Now there are many. Anti-infective is the main category. These are all things that stop infections. But within that, there are more precise terms. Antibiotics are drugs that kill bacteria or prevent bacteria from causing an infection. Antivirals work against viruses. Antiprotozoals fight protozoal infections. Antifungals, fungal infection. So if you say, I'm giving you an anti-infective, again, that's kind of like saying, here's meat for supper, instead of saying, here's hamburger. So I want you to always talk specifically to your patients. Some things that we'll always monitor when people have infections. Most common lab is the CBC, the complete blood count. And of the complete blood count, we're going to focus on the WBCs, the white blood count. Generally, when there's an infection, the white blood count goes up. When they're responding to the antibiotics, it goes down. Or the antivirals, it goes down. Now, other things can cause elevations, but when you see large elevations, it's almost always due to an infection. Antibiotics are started when it's suspected that there is a bacterial infection. Never viral, only bacterial. Now, antibiotic therapy can be started for two reasons: empiric therapy or prophylactic. Prophylactic would be sometimes some people who have had heart valve problems or knee surgery. If you go for dental work, you'll have to prophylactically take an antibiotic in advance to prevent an infection. That's prophylactically. You're preventing an infection. Empiric is you're treating based on evidence. It looks like there's an infection. Signs and symptoms of an infection. We're looking for therapeutic responses. Is the patient getting better? Is the fever going away? Is the redness and swelling going down if they have cellulitis? So that's a therapeutic response. There are resistant bacteria also. MRSA, MRSA, and VRE are two very common bacteria that are resistant. They're present all around us. We want to make sure that we carefully treat this so we don't spread them to other people. Now, when we're treating these bacteria, especially these bacteria, it's common to have to use powerful antibiotics. And these powerful antibiotics wipe out all the bacteria in our system, including all the stuff we really want in our system. Because, of course, we always have bacteria that is supposed to be living in our gut to help digest food and create chemicals that we need. But when we take these powerful antibiotics, it wipes everything out. And that allows some of these bacteria that are present in very small quantities to start growing. That's called a superinfection. Not super as in great, but it's an infection. It's an overgrowth of something that is always there in small quantities, and now it's been able to take over. The two most common superinfections we worry about: C. diff or Clostridium difficile, which is a terrible illness that causes profuse and dangerous diarrhea, and a yeast infection, Candida, vaginitis. There's many different yeast infections which are simple overgrowth of yeast. So when we're giving antibiotics or any medication, we always want to watch out for toxicities. And many of these toxicities can be monitored using lab values. I already mentioned the WBC, but that's only used to measure the therapeutic response to an antibiotic. We can look for hepatotoxicity or liver toxicity using the ALT and AST. If they go up, we're looking at the beginnings of liver damage. Nephrotoxicity or kidney toxicity is monitored by the BUN and creatinine. Now, many things can make that go up, most particularly dehydration. But if you're taking medications and it suddenly spikes up and you're still drinking the normal amounts, you could be experiencing some kidney damage. We're also looking at blood dyscrasias, blood illnesses, blood abnormalities. We could have anemia, and then we'll count the red blood cells, or the RBCs. We'll monitor the hemoglobin and hematocrit, also known as the H&H. We'll still monitor the WBC, but we'll monitor it for leukopenia or neutropenia, which would be a profound lowering of the white cells. We want white cell counts to go to normal. We do not want them to drop under normal. We can also watch for the platelet count, looking for thrombocytopenia or low thrombus levels, low platelet count. So those are the lab values that when we see these, we understand that there's possibly some toxic effects going on inside the body. Now, bacteria or antibiotics, there are many types of antibiotics. They fall into two categories, bactericidal and bacteriostatic. Bactericidals are killers. They kill the bacteria. And those are the bacteria that commonly will lead potentially to those superinfections when things overgrow. Bactericidal simply inhibit the growth of bacteria. They keep a lid on that, allowing your body's natural defenses to go in and take over it. So those are less likely to have that superinfection side effect. Which are which? For the cidals, we have the cephalosporins, polymyxin, vancomycins. The bacteriostatics would be the sulfonamides, erythromycin, lincomycin. Let's talk real briefly about one specific illness, tuberculosis. Tuberculosis is a bacterial illness, so it's treated with antibiotics, but it's treated with usually 2 or 3 or 4 antibiotics for 6 to 12 months, because this is a very difficult to kill bacteria. You need to take these medications for, again, 6 to 12 months. You're usually not infectious for that whole time, but you need to take them for that entire period, because if you take them only for a few weeks, you will kill off some of the bacteria that cause tuberculosis, leaving the strong ones behind. And that is how resistance begins. You're killing off the weakest, leaving the strongest bacteria to fight. So if you take your rifampin for, say, 2 or 3 weeks, and you stop it because you're developing the red discoloration to your urine and your tears and your saliva, and you just think that's just horrible and gross, and so you stop it, some of that rifampin has killed the bacteria, but a lot of bacteria will stay, and those are the tough to kill bacteria. So we want to make sure that whenever we prescribe an antibiotic, or we don't prescribe them, we administer them, but we want to teach our patients to take all of them. Not when they stop when they start feeling better, all of them. Antifungal drugs, two most common we're looking at would be amphotericin B and nystatin. Very frequently we'll give, especially with amphotericin, we'll give a test dose, because many people react very poorly to this drug. It's a very, very toxic drug. It works, but it's toxic. It's used for systemic infection. Nystatin is for topical infections. Topical meaning on the surface, systemic meaning body-wide. Antiviral drugs, viruses are very difficult to kill. And we commonly have immunizations to prevent viral illnesses. Immunizations are for smallpox, polio, chickenpox, mumps, rabies, influenza, hepatitis, herpes simplex, herpes zoster. All of these, there are immunizations to prevent those illnesses. It's so much easier to prevent than it is to eliminate. Sulfonamides, these are bacteriostatic, as I mentioned. They are good for preventing the growth of bacteria. They're made from sulfa, so there are many people that are allergic to this. If you have renal or hepatic disease, you really shouldn't take these. Almost every category of antibiotics causes nausea, vomiting, and diarrhea. It is the most common side effect to any antibiotic. It is one of the most common reasons people stop taking them, because they just feel sicker when they take those medications. Penicillin started in the 1940s. They remain a safe and effective antibiotic, although many bacteria are now becoming resistant to the psyllins. Cephalosporins are closely related to psyllins. If people are allergic to penicillin, they commonly will also be cross-allergic to cephalosporins. So something you have to make sure that you understand. What are the patient's allergies? There's first, second, third, and fourth generation cephalosporins. each of those covering different types of bacteria. And remember, bacteria are also categories in gram-positive or gram-negative. So each of these treats will tackle bacteria differently. First generation is very good for gram-positive, but very poor for gram-negative. Third generation, more potent for gram-negative than gram-positive. Fourth generation, it's the best for gram-negative. Also, like with the sulfonamides, if you have renal disease, you should use these carefully. Also, use these carefully if you're nursing, if you're lactating. Side effects are very similar to penicillins. Tetracyclines are another category of medication of antibiotics. These are bacteriostatic, very commonly used for skin infections. Acne is a big one. A couple key things you have to remember, though. First off, never give tetracycline with calcium or milk products because it will inhibit the absorption. So milk is a problem with that. It will bind to calcium and magnesium and aluminum. So antacids, Tums, Maalox, you can't give those because it will just totally eliminate the medicine from the body. It also has teratogenic effects. If you're pregnant or may be pregnant, or if you're a child under the age of 8 or 9, you can't use these because you will end up with discolored teeth and bones. It also may retard fetal skeletal development. So, again, pregnant women cannot use tetracycline. Adults who use it, it's commonly used in teenagers. I used it when I was a teenager for acne. Become very photosensitive. It also causes a lot of nausea, vomiting, diarrhea. It can cause dizziness and vestibular reactions, so inner ear dizziness. It's also nephrotoxic in high doses. Aminoglycosides. These are good for serious gram-negative infections. They have a half-life of only 2 to 4 hours. They're very short in the body. They are very prone to causing renal failure, or another word is nephrotoxic. If you're giving aminoglycosides, make sure, unless there's a reason not to, make sure you push fluids. You want to flush this out of the system. You want to keep the kidneys running at peak efficiency to prevent nephrotoxicity. The quinolones are bactericidal. These are used for respiratory infections, lower respiratory, bone and joint infections, infectious diarrhea. Again, nausea, vomiting, diarrhea, very common with these. We want to use these very carefully in children under 18 and the elderly. This is another one of the many antibiotics that causes Stevens-Johnson syndrome. So we want to watch for a rash over the whole body. Last category of antibiotics are the macrolides. Severe hepatic disease is an absolute contraindication for this medication. It's a broad spectrum antibiotic, which means it also has a good chance of causing one of those super infections when it kills everything and the existing bacteria start growing over. All right, that takes us through learning plan 4. Come back for the autonomic nervous system.